Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. It's my honor to be here again in the sleep session of the annual Congress of the Egyptian Society of Chest Diseases and Tuberculosis. Truly, it's a unique experience to meet all the sleep professionals all over Egypt every year in this time. And today, we will try to dig deep into one of the strongest or the known strongest metrics of the polysomnography for obstructive sleep apnea, which is the apnea-hypopnea index. We will try to unleash the uncovered side of the apnea-hypopnea index in this panel discussion. It's my pleasure to welcome the panelists in this session, Professor Mahmoud Ibrahim, Professor of Chest Diseases, Alexandria University, Professor Nashwa Hassan, Professor of Chest Diseases, Alexandria University, Dr. Miral al-Sharif, Lecturer of Respiratory Medicine, Al-Minya University. Albert Einstein once said that everything that can be counted does not necessarily count. We will try to apply this quotation for the apnea-hypopnea index, a countable polysomnographic measure. Does it still count or not? To know this, we must first know the evolution of the apnea-hypopnea index over the past century. The whole story started in the year 1978. Christian Guilleminot was the first to introduce the term apnea index, which is the total number of apneas per hour of sleep. He replaced this index by the total number of breathing cessations. He considered that it will solve everything, but we will see whether he was correct or not. In the next year came Geoffrey Block. Geoffrey Block was the first to introduce the cutoff point of 4% oxygen desaturation in the definition of the hypopnea. And in 1988, an experienced dentist, Joe Gould, he was interested in the hypopnea. He paid much attention for the hypopnea in identifying the sleep apnea syndrome. And he considered that apnea and hypopnea are equivalent in their symptomatology representing this syndrome. Years has passed, and in 1990, the first international classification of sleep disorder, the first version, was introduced. And in this, the criteria for diagnosis or scoring of obstructive sleep apnea was only based on the symptomatology. It lacked the apnea-hypopnea index. Came the second edition of the International Classification of Sleep Disorder in the year 2005, and in this, the scoring or the criteria of obstructive sleep apnea was a combination between the clinical symptomatology in addition to the apnea-hypopnea index. Now, how did the scoring manual of the American Academy of Sleep Medicine change in these two metrics? As regards the hypopnea, it has passed into two important endpoints. The first is in the year 2007, where the first version of the American Academy of Sleep Medicine scoring manual was introduced, and in this, the hypopnea was scored based on two rules, the recommended and the alternative rules. The recommended rule stated that there is a reduction of at least 30% in the airflow with a 4% desaturation, while the alternative rule considered a reduction in the airflow of 50% with a 3% desaturation or an occurrence of arousal. In 2012, the second version of the American Academy of Sleep Medicine scoring manual changed these definitions for scoring the hypopnea by the recommended rule of a reduction of 30% in the airflow with a 3% desaturation or occurrence of an arousal. But there was an acceptable criteria where the 3% desaturation was replaced by the 4% desaturation. For many years, obstructive sleep apnea was thought to be only an obstruction in the upper airway. The anatomical cause was the only factor explaining obstructive sleep apnea. Yet, important landmark in the year 2013 by Danny Eckert, where different pathophysiological mechanisms were identified beside the anatomical mechanism. These non-anatomical mechanisms included the low arousal threshold, the lazy upper airway dilator muscle or the poor responsiveness of the upper airway dilator muscle, and the high loop gain or the instability of the ventilatory control system. Maybe this could explain the heterogeneous nature of the disease. Now coming to the first part of this panel discussion, and my question is directed to Dr. Miral. Knowing that the apnea-hypopnea index was one of the most solid metrics of the polysomnography for diagnosis of obstructive sleep apnea and quantifying its severity, does it still worth it, or we need to ditch the apnea-hypopnea index?
Bismillah ar-Rahman ar-Rahim. First of all, thank you so much, Professor Dr. Iman, for your kind invitation, and congratulations on the great success of the conference. And regards to the apnea-hypopnea index, it's well known that it's part of the definition of obstructive sleep apnea, and it's used for the severity assessment and grading, ranging from 5 to 15 for mild cases and 15 to 30 for the moderate cases, and more than 30 events per hour of sleep for the severe cases. The events are including the apneas, hypopneas, and the diarrheas, without giving any information about the depth or the duration of the events, and this is one of the great limitations of the apnea-hypopnea index. In the meantime, the hypopneas and the apneas have the same weight in this calculation. Also, the hypopneas has gone through multiple changes in definition over the years. This is another one of the limitations. Another important limitation is the arbitrary 10-second duration of the event. Sometimes we find an event duration of 9 seconds associated with a substantial desaturation, and we ignore this event. This is another weak point. Yeah. Also, the apnea-hypopnea index duration, we will show some slides about the differences in duration. This one is showing a prolonged apnea, and the other slide will show multiple short hypopneas. Which one do you think is more hazardous? Is it the longer prolonged duration apneas or even hypopneas, or the multiple and frequent short duration events? And a study was done in 2019 shows that the frequent short duration events has a significant hazard ratio for all-cause mortality. And this is more than the prolonged hypopneas. Actually, the short duration events is a marker for the low arousal threshold that carries and reflects an important notification about the variability in the ventilation instability and augmented autonomic nervous system response that is contributing to the most serious adverse health consequences.
And even simply in the two figures you have shown, even the prolonged duration of the apneas was not associated with the desaturation, while the hypopneas was associated with the desaturation, although it was much shorter.
Another one of the greatest limitations that the desaturation is one of the part of the definition for hypopnea may or may not apply, but it doesn't. It's not important at all for the apneas. And as well, the importance that we should give is to assess the events and the apnea-hypopnea index that occurred during the REM sleep. Actually, the report gives out this percentage of apnea-hypopnea index, and we should give it extra care because the publications showed that the increased apnea-hypopnea index 15 or more has a higher risk for the prevalence of hypertension. On the other hand, when we use 4 hours of CPAP during sleep, this contributes to treatment of 40% of the REM events, and this is very good for the diabetic patient as it reduces the hemoglobin A1C by around 0.25%. And when we use the CPAP overnight during sleep for 7 hours, this will treat the apnea-hypopnea index during REM by 87%, and thus will correct the hemoglobin A1C up to around 1%. And this is great success for the diabetic patients with obstructive sleep apnea. So now we are highlighting the weak points of the apnea-hypopnea index, and that's why we need to try to find out another metrics that would be more helpful coherent and competent more than the apnea-hypopnea index. And this table is summarizing the available PSG metrics for measuring the obesity hypoventilation severity. The conventional one is the apnea-hypopnea index and ODI, and there is novel and promising metrics. My professors will show us about them.
Thank you, Dr. Miral. As Dr. Miral have said that several metrics are now being evolved and some of them showing much promise. Even the one metric called the hypoxic burden that we will discuss later on, this metric which is simply discusses the recording of the airflow with the oxygen saturation and synchronizing the saturation around the termination of the respiratory event to identify what's called the search window. This hypoxic burden have shown with the overall calculation of the area under the respiratory event desaturation curve, which have shown to be showing some promise. And my question goes to Professor Mahmoud Ibrahim. In this second part of the session, as we have unleashed the part concerning the apnea-hypopnea index, does the newly evolved metrics, such as the hypoxic burden, pose a promise for the field of diagnosis and quantification of severity of obstructive sleep apnea or not?
بسم الله الرحمن الرحيم. كل عام وحضراتكم بخير جميعا. شكرا لدعوتكم الكريمة. We started to look at further things as the symptoms, that the polysomnographic variables and some blood markers, try to find a more appropriate way of identifying the patient's sleep apnea. Next, please. So they started in the sleep heart study looking at the symptoms. If the symptoms have a way, and they started to divide the patient according to the sleepiness of the sleepiness. And they find, next slide, please. They find that the patients who are more sleepy are those who have higher mortality, higher stroke index risk, and coronary heart disease, and so on. So the symptoms are more important than the apnea-hypopnea index in this study. The more sleepy, the more the symptoms. Next, please. However, this was refuted in another study which was done in France in more than 5,000 patients, and they started to find that symptomatology alone did not explain the incidence and of the MACE, or the major adverse cardiac events that might occur. Next, please. And they found that the next, please. Next, please. And they found that the apnea. Next, please. The symptoms of the type were not associated with the MACE and after adjustment for confounders, but it is the T90 or the nocturnal hypoxemia that's more important than the symptoms. Next, please. Not looking at the polysomnographic variable, they start to divide the patient into those of the hypoxic, those with periodic leg movements, those with the hypopnea, apnea, and more comorbid events. And they look again at the major cardiovascular events. They found that the patients with hypopnea and hypoxia and the periodic leg movements are the most having the higher incidences of the major cardiovascular events. Importantly, the risk did not increase with apnea-hypopnea index. Next, please. And they found that the response of the CPAP also in these patients, those with the clusters with the passive periodic leg movements and with the hypopnea, are the more responders to the CPAP, and the others will not respond equally. Next, please. Looking at the same polysomnographic variable clusters, and they looked at the incidence of diabetes mellitus, they found that again the incidence of diabetes mellitus will increase in those with the periodic leg movement and those with the hypoxia. So the hypoxia is more important than the apnea-hypopnea index in predicting the incident diabetes. Next, please. Even if you look here, that the black in this curve, the black numbers are those who have apnea-hypopnea index, and the red ones are those attributed to the hypoxia, hypopnea, and the periodic leg movement, showing that the incidence of diabetes mellitus is more related to the hypoxia rather than the apnea-hypopnea index. Next, please. We did a study recently published in 2023, and we looked at the patients with diabetes mellitus, if they're controlled or uncontrolled, and we found that the predictors of control was the T90 rather than the apnea-hypopnea index. Next, please. Yeah, next, please. And they found that nocturnal hypoxemia could be an important factor affecting the glycemic control rather than the apnea-hypopnea index. Next, please. This is the hypoxic burden that Professor Iman just alluded to, and this was developed in Harvard University by Ali Azhar Barzin And it's not the number of ODI, but it's the desaturation, duration, and the event and the depth of the event. And they found that the clusters against the more the hypoxic burden, the more all-cause mortality and cardiovascular increases with the related mortality. Right, next please. Yes, and this shows that the response also of the CPAP is more with the hypoxic burden. The more you have hypoxic burden, the more is the response. And in this, it was more stronger than the apnea-hypopnea index, the ODI, and the T90. So the patients who have hypoxic burden, high hypoxic burden, are those who will respond to the CPAP. So we're looking at parameters that will look who will respond to the CPAP. Not all patients will respond to CPAP. Those with a high hypoxic burden will respond better. And as you'll see later, other parameters. So again, the hypoxic burden, the more hypoxic burden, the best response for the CPAP. Next, please. Next, please. These are the different studies comparing the apnea-hypopnea index with the hypoxic burden, and all showing a better response to the hypoxic burden, better correlation. Yeah. Even the response, if you have a patient with a cancer and a patient with obstructive sleep apnea, the mortality from the cancer itself would increase according to the presence of the nocturnal hypoxemia and sleep fragmentation, and rather than the apnea-hypopnea index in these patients. Next, please. When they divided patients according to the cardiovascular mortality again, and the clusters, if you look at the apnea-hypopnea index, it is non-significant. The mild, moderate, severe we're all looking at, it's non-significant correlation to the mortality and the morbidity and the cardiovascular events. However, looking at the hypoxic burden, it was more important, or the T90 and the hypoxemia. So we're looking at the severity of obstructive sleep apnea, not only the apnea-hypopnea index, we're looking on the symptoms, the comorbidities, the obesity, the sleepiness, and everything. So it's not only a number. Next, please. So this is the new staging of the sleep apnea or severity. It's the apnea-hypopnea index, the T90, the sleepiness, and the body mass index, and the very important if the patient have a cardiovascular or a metabolic disease. Next, please. And this led to what's called the Baveno classification, where apnea-hypopnea index is just a number to end this patient has sleep apnea. You know, we divide the patient according to the symptoms, A, B, C, and D, according to the COPD, according to the symptoms and the severity and the end organ affection. So if you look at the patient with a mild disease on the left-hand side, if we treated all the apnea-hypopnea index, we will lose much of the patients who have high symptoms and high end organ affection. We are not treated. If we treat according to the apnea-hypopnea index on the left side, we will treat less patients because these patients are severe but don't have symptoms and don't have end organ affection. So we have something called obstructive sleep apnea, which is just a number. And obstructive sleep apnea syndrome is the patient who has this number but has symptoms and has end organ affection. Next, please. So this is my last slide. Looking at the apnea-hypopnea index is looking at a person who is hammering a piece of wood. The number of hammers in the apnea-hypopnea index, regardless of the strength of the hammer, which is the hypoxic burden and the desaturation events and duration, and lastly, the piece of wood itself. So the patient, if he has metabolic activity diseases, he will be more prone to get symptoms of this patient. And I leave for Dr. Nasser to
Professor Mahmoud Ibrahim, if it was for you to choose one of the metrics to incorporate in the assessment of the severity or the diagnosis of obstructive sleep apnea, which new parameter would you involve in this?
Yeah, that, as I just mentioned, it's not only a number. We have to look at the patient, the symptoms, the night symptoms and the day symptoms. We have to look at the presence of this patient have atrial fibrillation, have a heart failure, have diabetes mellitus. So it is the symptoms that the apnea-hypopnea is a number. The hypoxic burden is very important. That's the degree of hypoxemia, and the symptoms of the patient, if it's sleepy or not, and the presence of metabolic and cardiometabolic events in this patient.
Even when they have searched for the identification of patients in the population with obstructive sleep apnea based on the apnea-hypopnea metric, this was highly prevalent. But when they found or searched for the symptomatic, among which they were much more less than those without symptoms.
Sure, yeah.
My third part of the panel discussion goes for the Professor Nashwa Hassan. The polysomnography is like a gold mine. It's rich in several variables that are poorly utilized for better assessment of obstructive sleep apnea and correlating with the risk outcome. Do we have that valuable data that we can extract from the polysomnography to identify the risk outcome in patients with obstructive sleep apnea?
Yes. في البداية بشكر اللجنة المنظمة على الدعوة الكريمة. When looking to the polysomnography parameter, apnea, hypopnea index, hypoxic burden, all are important, but we should look to cardiovascular response to apneas and hypopneas. Some parameters are very important. One of them is the pulse rate response. Next, please. All we know that patients with sleep apnea suffer from brachytachyarrhythmia due to, next, please, bradycardia that occur during the event itself and tachycardia occurring with the termination. If we measure the pulse rate response itself between the bradycardia and tachycardia, this is very important. If this is more than 6, next please. This is another
you mean the delta heart rate?
6 beats per minute.
Okay.
Yes. This is another polysomnographic study showing the pulse rate response. There is much more change in the pulse rate between during the event and with the termination of the event, even up to 50 beats per minute. This is very important in detecting the outcome and the response to CPAP treatment. Next, please. Next. Even with RERA, not only apnea and hypopnea, heart rate may decrease with RERA and there will be pulse response. Next, please. From the report of the polysomnography, we can recognize the bradytachyarrhythmia from the acceleration rate and the deceleration rate in the pulse rate, also by knowing the minimal heart rate and maximal heart rate. There is more correlation with the response or with the cardiovascular mortality and the morbidity and all-cause mortality with the pulse rate response more than apnea and hypoxic burden. If you look to the marked by yellow, the same patient, no please, the same slide please. Patient with the same apnea-hypopnea index and same hypoxic burden, but those who show high pulse response rate have high cardiovascular mortality and high all-cause mortality. So this is very important in the outcome of the patient. Next, please. In Ricat's study, they found that patients with ischemic heart disease who suffer from obstructive sleep apnea, those who have pulse rate response, they show more improvement with CPAP and less cardiovascular mortality. Another observation, but not statistically significant, that those patients with sleep apnea and low pulse response, they show less improvement on CPAP. So this is very important to detect treatment to the patient according to pulse response. Next, please. Another factor in the cardiovascular markers is the lung to finger circulation time. In polysomnography report, it is called circulatory delay. This is the time between the end of the event and the minimal oxygen saturation. This is correlated to the circulatory time. So if it is prolonged, this means that mostly the patient suffering from heart failure. But there was found very important correlation with the outcome of the patient who have more prolonged circulatory time. They have more cardiovascular morbidity and mortality and all-cause mortality than those having short circulatory delay. So this is very important parameter to look in polysomnography. The last one I will speak about is the blood pressure nocturnal pattern. Normally, there is dipping in blood pressure during sleep, but most of patients with sleep apnea suffer from non-dipping phenomena. This could be attributed from the polysomnography. Next, please. This is an epoch of the polysomnography for patients suffering from sleep apnea. Next. From the report, we can know the average systolic pressure and average diastolic pressure and comparing it to the blood pressure of the patient before sleep. If there's no dipping, this means that non-dipping phenomena is present in those patients, and this is correlated to the prognosis of the patient. Next, please. The same patient on CPAP, there's no change in blood pressure. So CPAP improved the pulse response and improved blood pressure changes. Next, please. Next. Blood pressure non-dipping is very important in prognosis of patients. They found that there is correlation with the new incident diabetes mellitus in patients with sleep apnea with presence of non-dipping phenomena. Also, next please, it is a prognostic parameters in patients with hypertension And in patient with arterial stiffness, it is more important parameter to predict arterial stiffness than other parameters. Thank you.
Thank you, Professor Nashwa. By this, we get to the conclusion of this panel discussion. The apnea-hypopnea index is not a one therapy or a one-size-fits-all. You need to apply the therapy targeted to the underlying pathophysiological mechanism of each individual patient with obstructive sleep apnea. The current metrics, the apnea-hypopnea index, although this metric served well in the past century, yet it's time, because of its limitation, to change. The novel measures that are being introduced, including the hypoxic burden, should be used widely as an alternative for the apnea-hypopnea index, because they pose three-dimensional view of the depth, duration, and frequency, not just frequency-based as the apnea-hypopnea index. And the novel cardiovascular markers, such as the pulse rate response, the non-dipping, and the lung finger circulation time, they are important because they can be correlated directly to the outcome of the patients, especially for the cardiovascular events, more than that with those measures such as the hypoxic burden and definitely the apnea-hypopnea index. And finally, my take-home message is it's time to release the apnea-hypopnea index as a mainstay for obstructive sleep apnea diagnosis and to start using more precise clinical markers. Thank you, and I would like to thank greatly the panel discussion with me, the panelists, Professor Mahmoud Ibrahim, Professor Nashwa Hassan, and Dr. Miral Al-Sharif. Allow me to introduce Professor Ashraf Shura. Welcome, Professor Ashraf.
شكرا أستاذ دكتورة إيمان على المحاضرة الجميلة وعلى التوضيح موضوع الابنيا هايبوبنيا اندكس فور اسسمنت اوف سيفيريتي اوف اوبستراكتيف سليب ابنيا. هو فعلا الابنيا هايبوبنيا اندكس لوحده مش معبر عن السيفيريتي الحقيقيه. يعني ممكن عين يبقى الابنيا هايبوبنيا اندكس بتاعه مثلا 20، ال 20 دي تبقى مودريت، والعين الثاني برضه 20 برضه مودريت، ولكن من عيان لعيان تختلف كتير زي ما الاستاذ دكتور محمود، دكتوره نشوى، دكتوره ميرال وضحوا ان الابنيا هايبوبنيا اندكس ما بيفرقش الابنيا عن الهايبوبنيا. يعني افرض عين عنده 20 بير اور، ال 20 ابنيا زي ال 20 هايبوبنيا، في حين ان الابنيا غير الهايبوبنيا. مش بيراعي الديوريشن من اول 10 سكندز، من اول 10 سكندز ده بيعتبرها ايفنت. في عيان الابنيا بتقعد معاه 10 سكند، في عيان بتوصل لحد 50 و60 سكند. فطبعا كل ما زادت الديوريشن كل ما زاد البردن على العيان. الهايبوكسيميا في حد ذاتها برضه او الديساتوريشن مجرد 3% دروب عن البيز لاين ده بيعتبر ديساتوريشن، في حين ان العيان ممكن يصل الديساتوريشن فيه اكتر من كده بكتير. بس هو فاحنا فعلا محتاجين اندكس يراعي الديساتوريشن، يراعي الابنيا، الهايبوبنيا، التايم نفسه، الابنيا نفسها او الايفنت ديوريشن مش كله يتساوى. مش اللي بيجي لي بابنيا 10 ثواني زيه زي اللي بيجي بابنيا 60 70 ثانيه. الامباكت على الكارديو فاسكولار اكشن، العيان اللي بيبقى ريفلكتد الهايبوكسيميا ريفلكتد عليه بتاكيكارديا ونوكتورنال هايبرتنشن واريزميا، غير العيان اللي مش بتبقى ريفلكتد عليه بمشاكل زي كده. فكل ده لازم يعني محتاج فعلا موديوليشن ومحتاج اندكس يبقى فعلا معبر حقيقي اكثر دقه عن الابنيا هايبوبنيا اندكس. شكرا استاذ دكتوره ايمان، وشكرا دكتور محمود، دكتوره نشوى، دكتوره ميرال.
Thank you, Professor Ashraf. And now we call for the end of this panel discussion, and we invite the multidisciplinary session, the next multidisciplinary session. We introduce Professor Lucy Sulaiman, the moderator, Professor of Chest Diseases, Mansoura University, the panelist, Professor Safi Qaddah, Professor of Chest Diseases, Cairo University, Professor Jayda Mekki, Professor of Neuropsychiatry, Alexandria University, and Professor Maha Yusuf, Professor of Chest Diseases, Munafia University. Thank you.
السلام عليكم. في البداية أحب أشكر طبعا الجمعية الأم على الدعوة الكريمة، وأخص الدكتورة إيمان جلال صديقتي وأختي وأستاذتي وكل حاجة يعني، وطبعا قدوتي في السليب وفي امراض النوم والشيست كله يعني. الف شكر دكتوره ايمان. ونبدا ان شاء الله. احنا طبعا الدكتوره ايمان لما قالت لي عايزين نعملها مالتي ديسيبلينري ديسكشن، فحاولنا ان احنا نشوف حاجه تكون يعني سليب بس ما ننامش بقى، يعني قلنا ايه نفوق كده، فقلنا نعملها في شكل كيس مالتي ديسيبلينري كيس، بحيث ان احنا نقدر نوصل منها المشكله بتاعه الكوميسار، لكن بشكل ان شاء الله يكون سيمبل، ونقدر ان احنا نوصل منها انفورميشن وتيك هوم مسجز للحضور جميعا. EUSA Insomnia and Restless Leg Syndrome Commissar Triple Calamity Discussion. Our agenda today طبعا معايا البانلست ببروفيسور دكتور صافي ودكتوره مها يوسف ودكتوره جيداء مكي من قسم النيورولوجي، استاذ نيورولوجي. Our agenda today هنتكلم الاول، هنستعرض الكيس، وبعد كده هنعمل كيس 3 problems discussion، وبعد كده هنشوف learning points from our discussion. The first problem is obstructive sleep apnea. 47 years old female patient presented with worsening daytime somnolence over the last 4 years. Her principal complaint were loud disruptive snoring, which was adversely affecting her marriage. She woke up unrefreshed and tired in the morning. She sought medical advice that the GP advised her for referral for the sleep assessment in the sleep clinic. دكتور صافي هنتكلم الأول إيه السليب clinic evaluation which done for our patient firstly.
بسم الله الرحمن الرحيم. أحب أشكر الدكتورة إيمان على الدعوة الكريمة، وبهنيها على التنظيم الرائع ومؤتمر ناجح بإذن الله. واشكر طبعا شير بيرسونز دكتور اشرف ومحمود، وبيسعدني ويشرفني ان اكون مع دكتوره لوسي ودكتوره مها ودكتوره غيداء في السيشن دي. السليب يعني كلينيك ايفالويشن بتاعنا، اول حاجه هنبقى فيه كلينيكال، هنبقى العيان ده بيشتكي ان في اكسسيف داي تايم سليبنس، هنأسس بالايبورس سليبنس سكيل كوشنير بتاعنا، وفي كمان البرلين كوشنير ممكن نستخدمه. في الستوب بانج سكور بنعمله، بنقيس كل واحد فيهم من الاسم السنورنج، اذا كان في تايردنس العيان بيقوم الصبح تايرد، اللي هي كان برضو من ضمن الشكوى العيانه المريضه دي. الاوبزرفد ابنيا، البلاد بريشر بتاعه لو كان في موجود هايبرتنشن او لا، والبانج بنقيس البودي ماس اندكس بتاعي. طبعا كل احنا معروف ان في طبعا ريليشن ما بين الاوسا والاوبيزيتي. النك سيركمفرنس بيفرق معايا، بنقيسه الويست سيركمفرنس. كمان الجندر المفروض انها تبقى اكتر في الميل، العيانه بتاعتنا المره دي في ميل. ومن ضمن الحاجات ان احنا ممكن نريفير لو اضطرينا، لان في كمان في سنورنج، ان انا اعمل ENT اكزامينيشن اتاكد ان ما فيش في العيانه دي في بوليبس او ادينويدز موجوده معايا. وهيفضل الاند ريزلت او الدايجنوستيك ان انا اعمل للاوسا هو الفول نايت بوليسومنوجرافي، ان ده ممكن اقيس بيه اذا كان في ابنيا او هايبوبنيا اندكس، او ان انا اشخص بيه الاوسا. في العيانه بتاعتنا دي الايفالويشن بتاعها الايبورس سليبنس سكور بتاعي كان 18 من 24. هو عباره عن كوشنير ان انا بيبقى فيه 8 سيتويشن، قابليه العيان قد ايه يدوز اوف، ان ممكن يعني بياخد من 0 لو ما فيش، او من 1 2 3 حسب السيفيريتي، انه قابليه انه يدوز اوف في سيتويشن معينه زي بيتفرج على التلفزيون وهكذا، او بيبقى في وسط كلام مع الناس. برلين كوشنير كان واخد فيه من 3 من 3، والستوب بانج كان في السكيل بتاعي واخد من 5 من 8، وطبعا البودي ماس اندكس بتاعه كان 40، وده معناه ان هو العيانه كانت سيفير اوبيزيتي. بالملامباتي سكور هنلاقي ان هي كانت كلاس 2، ان هنلاقي ما فيش مش شايفين غير التيب بتاعه اليوفيلا، والبس البيز اوف اليوفيلا هي اللي باينه، السوفت باليت مش واضح. النكست سكيل، نكست سلايد. هنعمل بعد كده البوليسومنوجرافي بتاعنا، هنلاقي في الريبورت العيانه طالع الابني هايبوبنيا اندكس بتاعتها 52.7 بير اور، وده معناها انها سيفير. احنا عارفين الابنيا من لو مايلد بتبقى الابنيا هايبوبنيا اندكس من 5 لحد 15، وبعدين من 15 لحد 30، اكتر من مودريت، واكتر من 30 هتبقى بير اور، هتبقى ان دي عباره عن ان في سيفير اوبستراكتيف ابنيا.
شكرا دكتورة صافي. طبعا احنا كنا عايزين نشوف هل في correlation بتبقى موجودة between the severity of the symptoms and the severity of apnea hypopnea index. يعني هل زي ما كان السيشن الدكتورة إيمان بتتكلم السيشن اللي قبلنا، هل دايما السيفيريتي بتاعت السيمتوم بتبقى coapted أو correlated مع السيفيريتي of the apnea hypopnea index؟
هو هنلاقي ان الابنيا هايبوبنيا اندكس لا ما فيش كورليشن ما بين السيفيريتي بتاعت الابنيا هايبوبنيا اندكس والسيماتولوجي بتاع المريض، وزي يمكن زي ما تفضلوا في السيشن اللي قبلنا كانت بوضوح اكتر ان كل ممكن تفرق كتير، ان ممكن يبقى الابنيا غير الهايبوبنيا، وتفضل دكتور اشرف بشرح الموضوع. فطبعا لا مش ما فيش، والموضوع ممكن يعتمد السيمتومز دي على حاجات كتير، على الايدج، اللايف ستايل بتاعت العيانه، اذا كانت بتشتغل او لا، عندها كوموربيديتيز معاها هايبرتنشن او لا. معروف ان القوسه طبعا بيبقى معاها اكتر ان يبقى في كميه كوموربيديتيز زي دايابيتس، هايبرتنشن، انسولين ريزيستنس. ممكن كل دول هم اللي يفرقوا في السيمتوماتولوجي او يخلوا السيمتومز مور سيفير عن ان انا اعتمد بس على الابنيا هايبوبنيا اندكس بير سي يعني.
Thank you دكتور صافي. طيب as regard to obstructive sleep apnea per se، هي الافكت بتاعها just ان بيحصل apnea and hypopnea with frequent arousal and nocturnal shocking، ولا في other background of the effect of obstructive sleep apnea on our sleep quality؟
القوسه في حد ذاتها الابنيا والهايبوبنيا طبعا ممكن يبقوا بعد كده يبقى في الاراوزل ده بيخلي في فراجمنتيشن للسليب، والعيان يبقى الكواليتي اوف سليب بتاعه تبقى افكتد. لما الكواليتي ممكن كمان ان العيانين دول تبقى افكتد ان بيبتدي كمان الشوكينج اللي بيبقى موجود معاها، انه يصحى عايز ياخد نفس وهكذا، ممكن بيقوم بيخلي فيه فراجمنتيشن للسليب. البوليوريا اللي موجوده او معروف انها تبقى اسوشيتد مع القوسه برضو ممكن تخلي العيان يدخل الحمام كذا مره. في بعض العيانين ريبورتد ان صوت السنورينج بتاعهم هو نفسه صحي على صوت بتاع السنورينج. وبالتالي المعروف طبعا ان كمان ان القوسه بتانتربت وممكن تانترفير مع الريم سليب او كمان السلو ويف سليب، وبالتالي ممكن تخلي العيان يبقى عنده مشاكل تانية اخرى تأفكت الكواليتي اوف سليب.
ثانك يو دكتور صافي. وبالفعل طبعا ان معظم العيانين بتوع الاوبستراكتيف سليب ابنيا بيكون مشكلتهم الاساسيه حتى لو ان هو بياخد number of hours of sleep sufficient، لكن المشكله ان هو بيكون الكواليتي اوف سليب نفسها changed بسبب نقص السلو ويف سليب and REM sleep due to frequent apnea and hypopnea. السكند بروبلم زادت شويه، ما عادتش obstructive sleep apnea بس، لا بقت كوميسا، يعني obstructive sleep apnea with comorbid insomnia. The patient is clearly has sleep initial and maintenance insomnia, and this is explain her daytime sleepiness and tiredness. But the most striking point زي ما قلنا ان she is actually getting a significant amount of sleep time. She went to the GP for this problem, and he is reluctant to prescribe her any hypnotics. He gave her only sleep hygiene advice and asked him to this will take time and her sleep will settle down again. sleep hygiene من الحاجات اللي هي بتبقى يعني ناس لما بيبقى عيان في عنده انسومنيا ممكن ما بيعتقدش فيها قوي، لكن هي very important ان انا instruct the patient firstly انه لازم طبعا انه ياخد avoid the caffeinated drink, take exercise, warm bath before sleep, ensuring طبعا ان الروم تكون comfortable and very dark. ما يكونش فيه اي devices موجوده electronic devices في الروم عشان avoid السليب. Do you think this is sufficient for patient of insomnia؟ الحقيقه معظم الستاديز اللي اتعملت وجدوا ان sleep hygiene intervention alone لان البيشنت ما بياخدوش بريسبكشن، فبالتالي ما بيكونش كافي ان هو يساعد العيان على التريتمنت، فبالتالي بداوا يحطوه في بارت من التريتمنت اوف انسومنيا اللي هو cognitive and behavioral therapy. لما اتحط على ان هو cognitive and behavioral therapy اصبح beneficial في التريتمنت ان هو حسن الكواليتي اوف سليب بالذات الانيشال انسومنيا عند بعض العيانين. دكتور مها، do you think this is a correlation between obstructive sleep apnea and this insomnia which developed in our patient؟
بسم الله الرحمن الرحيم. في البداية أشكر دكتورة إيمان على الدعوة الكريمة، وشرفني إن أنا أتشارك المنصة معاها مع أساتذتي دكتور محمود إبراهيم ودكتور أشرف شورى ودكتورة صافي ودكتورة جيدي. حقيقة ممكن العيان يبقى عنده two diseases obstructive sleep apnea with insomnia، وبسميها obstructive sleep apnea with comorbid insomnia واختصارها كوميسا أو sleep apnea plus. وده الرينج بتاعه very variable زي ما هو مكتوب كده from 7 to 57. وحوالي 50% من العيانين اللي عندهم severe obstructive sleep apnea بيبقى عندهم comorbid insomnia، على الرغم من ان التو diseases are يعني separate diseases. each disease has separate pathophysiology، بس الاثنين كان maybe coexist in the same patient، ودول هيعملوا mediation للمانجمنت بتاعنا في البيشنت.
Thank you دكتور مها. طب as regard to the OSA and insomnia، ايه الانتراكشن او الباثوفيسيولوجي اللي بيجمع بين الاثنين او يفسر حدوث الانسومنيا with obstructive sleep apnea؟
انا هبدا بالباثوفيسيولوجي بتاع الاوبستراكتيف سليب ابنيا. المين باثوفيسيولوجي هو انترميتنت هايبوكسيا مع ريبيتد سليب فراجمنتيشن. ده بيعمل اكتيفيشن لسمباثيك سيستم مع الهايبوثالامو بيتويتري ادرينال اكسس، فبيعمل زي هايبر اراوزال ستيت عند العيان. والهايبر اراوزال ستيت يعني انكريز في الادرينالين والكورتيزول ليفل في البلاد داي اند نايت. هو ده احد الباثوفيسيولوجيكال ميكانيزمز اللي تخلي العيان عنده انسومنيا. الاكتيفيشن اوف ذا هايبوثالامو بيتويتري اوفريان اكسس ده ادرينال اكسس بيعمل اوبيزيتي وبيخلي العيان لايبل تو مور اوبستراكتيف سليب ابنيا، وبيعمل جلوكوز انتوليرانس. وبعض الاستاديز قالت ان الامبيرد جلوكوز ليفل ممكن يعمل مور اوبستراكتيف سليب ابنيا. على العكس الانسومنيا ممكن تعمل مور اكتيفيشن للسمباثيك سيستم، يعني مور هايبر اراوزال ستيت، وممكن تعمل تدخلنا في السايكل دي. يعني هم تو سيبريت ديزيزز، بس لو اتوجدوا الاثنين في نفس العيان كل ديزيز منهم هيعمل وورسننج للاذر ديزيز.
ثانك يو دكتور مها. decision making، لان كتير بنتسال امتى العيان بتاع الانسومنيا اطلب منه انه يعمل بولي سومنوجرافي. هل اي عيان complaining from insomnia دكتور ما نعمل له بولي سومنوجرافي؟
As a gold standard, polysomnography is not indicated in a patient with insomnia except لو العيان انا suspecting ان عنده other sleep disorder، يعني العيان عنده insomnia ما بينامش بس انا شاكك ان هو عنده sleep apnea هي اللي عامله repeated sleep arousals and sleep fragmentation مثلا. او العيان جاي لي بشكوى غريبه، عيان بيؤكد ان هو ما بينامش ولا دقيقه بالليل. في هذه الحاله انا بعمل له polysomnography اولا عشان اقنعه ان هو بينام، بس بينام نوم خفيف. العيان ده من الريبيتد سليب فراجمنتيشن او من الهايبر اراوزال ستيت بيبقى معظم السليب بتاعه لايت سليب ومينلي ان 1. في ستيج ان 1 العيان نايم ومغمض عينيه او مسترخي ومغمض عينيه وسامع اللي حواليه. الاي جي بتاعه يجيب ان 1 اللي هي الفيرست ستيج اوف سليب، هو سامع عشان كده شايف ان هو مش نايم. ده بيخلي العيان الصبح يقول انا ما نمتش ولا دقيقه، حاجه بنسميها بارادوكسيكال انسومنيا.
ثانك يو دكتور مها. طبعا المشكله بتاعه الكوميسا ان هي بيكون شيرنج الاوبستراكتيف سليب ابنيا ويز انسومنيا زي ما الدكتوره مها قالت. العيانين دول بيبقى فيهم difficulty of falling asleep, unrefreshing sleep, impairment في الميموري, daytime sleepiness, less of motivation to anything. كان في بيبرز بتتكلم عن البريفالنس بتاع الكوميسا، وجدوا ان البريفالنس بتاعها فعلا كبير جدا، ما يقرب من حوالي 30%، وان الكومباينيشن الاثنين مع بعض الاوسا مع الانسومنيا بيزود كاميولاتيف ريسك للكارديوفاسكولار ديس اوردر. التريتمنت بتاع الكوميسا في الغالب بيعتمد على الباب ثيرابي، يعني برضو ان انا بعالج الكوز اللي هو الاوبستراكتيف سليب ابنيا. however ان most of these patients وجدوا ان هم بيكونوا less compliant and adherence للسباب ثيرابي. فعلشان كده لازم نضيف معاهم الكوجنيتيف اند behavioral ثيرابي تو امبروف السليب انيشال انسومنيا اند امبروف اولسو السليب كواليتي. The third limb of our discussion is third problem. كبرت شويه بقى من obstructive sleep apnea الكوميسا، لا بقت كوميسار لان العيانه complaining from also restless leg syndrome. She dated his problem to a knee operation as it was a number of months after this that she would find her overnight sleep becomes unrefreshed. In addition to worsening of the night symptom والانسومنيا she had increasing daytime headache. بدأت تلاحظ ان في twitches بتحصل في الليج and upper arms and she jumps of her legs as she goes off to sleep. Her partner كمان notice ان في jerks during sleep. She has stopped all caffeinated drink 2 years ago. However, patient developed this complaint. دكتور جيداء, do you think this is a restless leg syndrome or periodic leg movement, and how I reach to the diagnosis of restless leg syndrome?
السلام عليكم. انا شاكره جدا طبعا دعوتي في المؤتمر. مبروك نجاح المؤتمر. ممتنه جدا لقعدتي في وسط بانلست وتشير بيرسونز الواحد كان يحلم يقابلهم يعني. انا طبعا من معسكر الاعداء، انا نيورولوجيست مش بالمونولوجيست. فالريستلس لاج سندروم بنصنفه في النيورولوجي كواحد من اكتر الانفولانتري موفمنتس الاندر ريكوجنايزد. اي حد عنده diurnal variation، يعني الموفمنت دي بتظهر في وقت بالليل اكتر من النهار. it is painful في الاول و relieved partially by movement. كمان هي بتبقى exacerbated at rest مش during activity، يعني العين عمره ما يحس restless leg syndrome during activity، عشان دي واحده من الحاجات اللي بتفرقها عن الكرامبس، ودي من الحاجات المنتشره جدا عندنا.
حضرتك ازاي how to diagnose only overwhelming ان في urge and itching، ولا نقدر نفرقها ازاي من ال other diseases؟ يعني what is the diagnostic criteria for restless leg syndrome؟
دايما السنسوري مانيفستيشنز اللي بتحصل قبل الريستلس سندروم بتبقى بوزيتيف سيمبتومز، يعني tingling، aching، cramping، اي abnormal sensation بنسميها الباراستيزياز، فالعين بيحس بيها. بالمناسبه ممكن تحصل upper limb و lower limb، بس they are more common by far more common في lower limbs، وممكن تكون unilateral او bilateral. زي ما قلت diurnal variation واحده من الحاجات اللي بنرجحها ان هي تكون بترشح حاجه زي كده. البيشنت نفسه sometimes he is aware الموفمنت ممكن تكون very mild، يعني ممكن يعمل فلكشن بسيط يستريح، وممكن تكون as aggressive as kicking كأنه بيرفس اللي جنبه في السرير.
Thank you دكتور جيداء. الريسك فاكتورز بتاعت الريستلس ليج سندروم وجدوا انها بتبقى موجوده اكتر في الومن اكتر من الميل. الايج بتاعها بيكون اكتر في الميدل ايج، بيكون في الغالب في فاميلي هيستوري. البريجنانسي في الغالب بيأجيتيت او بيأجريفيت المشكله بتاعت الريستلس ليج سندروم. الكرونيك ديسيز زي الرينال فيلير وزي النيوروباثي وزي الانيميا والايرون ديفيشنسي. بعض الميديكيشن زي الانتي نوزيا والانتي سايكوتيك والانتي ديبريسنت من الحاجات اللي بتزود الريسك بتاع الريستلس ليج سندروم. اند اولسو اثينيتي. الديفرنشال دياجنوز مهم جدا ان انا لما العيان يجي لي افرق ما بين ان ده مش كرامب. الكرامب ده بيكون فيه sudden onset of severe pain associated with muscle spasm relieved by stretching، ان هو مش نيوروباثي لان ده بيكون constant discomfort tingling، انه مش vascular insufficiency لان ده بيورس اكتر مع الموفمنت بعكس الريستلس ليج سندروم اللي بيمبروف مع الموفمنت، مش arthritis لان بيبقى associated مع joint pain، ولا akathisia اللي بيبقى فيها intense restlessness not usually relieved by movement associated with neuroleptic use and drug withdrawal. دكتور جيداء، احنا عايزين نشوف هل المنظر اللي احنا شايفينه ده ريستلس ليج سندروم؟
يعني احنا الموفمنت اللي بيشوفها العيان بتبقى بيعمل دورسي فلكشن كانه بيشد رجله على ورا وبعدين بينزلها على قدام as if he is stepping on something، يعني ده المنظر الكلينيكال بيتشاف على العيان. وزي ما قلت لكم ممكن تكون خفيفه جدا ما تبانش الا على الليفل بتاع الاي ام جي، وممكن تكون فيزيبل للباد بارتنر، وممكن تكون انجوريوس للباد بارتنر، ممكن تخبطه. المنظر اللي احنا بقى بنشوفه في البوليسومنوجرام لو حضراتكم شفتوا كده الاروز اللي لونها احمر دي، البريودك ليم موفمنتس من الحاجات اللي بتيجي كلاسترز، يعني هي مش بتيجي مره عشان نفرقها عن اللي بيتقلب او بيتحرك، فهي بتبقى كلاسترز يجوا ورا بعض ليهم انترفال وامبليتيود معين بنقدر نشخص بيه ان دي ديفينيت ريستلس ليج.
ثانك يو دكتور جيداء. ايه الانفستيجيشن اللي موستلي نعملها عشان اتاكد الريستلس ليج سندروم ده برايمري اور سكندري؟
واحنا بنصبح على العيان نعمل له سي بي سي، السيرم فيرتين بتاعه، البلاد شوجر والهيموجلوبين A1C، بنشوف الرينال فانكشنز بتاعه العيان، ده بيزك. other additional investigations لو انا suspecting another cause for peripheral neuropathy، pregnant ولا لا، عندي فيتامين دي deficiency والثايرويد بروفايل، كل الحاجات دي بتأفكت السليب overall، فممكن exacerbate another sleep disorder.
Thank you. And what is your management plan for this patient؟
حالات الريستلس لاج سندروم ليها نون فارماكولوجيكال تريتمنت، اللي بنقول للعيان الريجولار فيزيكال اكسرسايز بالنهار من الحاجات اللي هتساعده. لو يقدر يعمل مساج لرجليه بالليل، يعني as simple as تحط كريم على رجلك وخلي الدايركشن اوف موفمنت بتاع ايدك والكريم من الرجلين للركبه، يعني من تحت لفوق. الهوت باثز من الحاجات اللي بتفرق كتير جدا في الريستلس لاج سندروم. الادويه اللي مستخدمه في عائله كامله اسمها الدوبامين اجونست احنا بنستخدمها، ودي عائله احنا بنستخدمها عاده في علاج الباركنسونز ديزيز، لان ده مرض ممكن يبريسيد او يبقى اسوشيتد مع حاجه زي الباركنسونز ديزيز. البنزودازيبينز لونج اكتنج بس بصراحه بنخليها اخر ريزورت تستخدمه، لان معظمهم ما بنعرفش نعمل منه withdrawal والعين ممكن يبقى ديبندنت عليه.
ثانك يو دكتور جيداء. So it's very important. كان في paper في ال sleep better عن ال improvement sleep hygiene to mitigate restless leg syndrome and obstructive sleep apnea. إن ال sleep hygiene إن أنا أحافظ على dark quiet cool room و turn off كل الإلكترونيكس بيعمل more improvement ل both obstructive sleep apnea and restless leg syndrome. بالنسبة لأور كيس طبعا كانت treated بالأورونيزال CPAP therapy and we repeat study after titration للسليب apnea. وجدنا إن البيشنت الأبنيا هايبوبنيا اندكس بتاعتها نزلت ل 0.1 يعني completely improved. 2 weeks later كان العيان تقريبا معظم الأوسا symptom اختلف with partial improvement for insomnia and restless leg syndrome. 2 months after cognitive and behavioral therapy and good sleep hygiene البيشنت كان حوالي 70% improved. The last point, our take-home message, and there is a relative poor correlation between severity of sleep apnea and measurement of apnea-hypopnea index. Apnea and hypopnea during sleep result in frequent arousal وبالتالي هي اللي بتعمل ال poor sleep quality. ال prevalence بتاع ال obstructive sleep apnea مع ال insomnia is very high بالذات ال maintenance insomnia. However, the result of sleep hygiene intervention is disappointing, but it's very important as a cognitive and behavioral therapy. Coexisting of restless leg syndrome and OSA is very common but less studies. The best treatment ان انا طبعا لازم اعالج السبب الاول بتاع الكوميسار زي الobstructive sleep apnea in our case. Cognitive and behavioral therapy is very important and should be respected after full investigation for our patient. وفي الاخر دي بيبر كانت معموله قريب جدا في شهر 6 عن الكوميسار. وجدوا ان طبعا الكونكلوجن ان الريسلس ليك سندروم والاوبستراكتيف سليب ابنيا من الحاجات اللي بتعمل انسومنيا وبتعمل كوجنيتيف اند ميتابوليك اند سايكاتريك ديس اوردر. And thank you for all and I wish you for all sweet sleep.
I'd like to thank the moderator and the panelists of this session. Thank you, and we will call now for the next part of the session, which is an international speaker, the Professor Ahmed Behammam.
السلام عليكم. السلام عليكم. السلام عليكم ورحمة الله وبركاته.
السلام عليكم.
السلام عليكم ورحمة الله وبركاته. هل الصوت واضح؟
الصوت واضح جدا دكتور أحمد.
يعطيكم العافية جميعا. تفضل دكتورة.
I'd like to welcome Professor Ahmed Behammam, our international guest speaker. Professor Ahmed is the University Sleep Disorder Center, Department of Medicine, College of Medicine, King Saudi University. And today, Professor Ahmed will give us a presentation concerning the residual sleepiness in obstructive sleep apnea patient. Good morning, Professor Ahmed.
صباح الخير أو مساء الخير. شكرا بروفيسور إيمان للدعوة الكريمة. حقيقة يسعدني ويشرفني أكون مع إخوتي وأحبتي في مصر العزيزة الحبيبة علينا جميعا في العالم العربي ونشارك معكم في هذا المؤتمر الناجح ما شاء الله. I'll talk today about residual sleepiness and obstructive sleep apnea. And the previous two sessions have discussed in depth sleep apnea, so I don't have to cover this much. But what I want to say here that sleep apnea present with several symptoms. One of them is daytime sleepiness, and this can be present in up to 60% of patients with sleep apnea. As you know, sleep apnea is very common, and now we know it is also common among women, not only men, as we used to think before. And the main treatment, again, as you know, is the CPAP treatment, and we'll talk about residual sleepiness after CPAP treatment. CPAP simply acts as a splint where it opens the airway by using positive airway pressure plus other mechanisms. However, we have to remember that there are effective alternative treatments for sleep apnea that we'll cover briefly in this talk, like the mandibular advancement devices, the hypoglossal nerve stimulation with its new modalities and techniques, and different surgeries like the maxillomandibular advancement surgery all these techniques are approved by the FDA to treat sleep apnea. When we assess sleepiness, there are objective tests and subjective tests. However, none of them is really perfect to assess sleepiness, and the commonest subjective test is the Epworth Sleepiness Scale, which has problem with reliability and the ability to reproduce the same results. Therefore, to assess sleepiness, we need a comprehensive sleep history by the specialist. It's important to take a good history, detailed history from the patient and from the bed partner or family member, because ESS may underscore or underestimate the sleepiness of the patient. We know all that sleepiness is associated with multiple problems like accidents, decreased performance, but recent data suggests that sleepiness also predicts morbidity and mortality in sleep apnea, not only quality of life and behavior. And there are several studies and randomized controlled trials assessing that. And sleepiness and sleep apnea have been linked, this have been covered briefly in the previous talks, with increased risk of all-cause mortality, cardiovascular event, cardiovascular mortality, stroke. However, not all studies are consistent. There are some contradictory findings, and we are probably looking into different phenotypes of sleep apnea, those with sleepiness and those without sleepiness, and sleepiness have been linked with coronary artery disease and elevated cholesterol levels, higher blood pressure, and increased sympathetic nerve activity, all putting the patient at higher risk for cardiovascular morbidity and mortality. The main point here that we have to realize that residual sleepiness in OSA patient after proper treatment has been reported in 9 to 22% of patients. So it is a very common problem even after proper treatment. Another important point that we'll come to it later, that the longer duration of CPAP treatment or other modality of treatment, the better the improvement in sleepiness. Therefore, it is recommended not to diagnose people as residual sleepiness in OSA until you treat them for 6 months. And we'll come to that point in more details. And few characteristics and predictors have been identified in patients who are likely to have residual daytime sleepiness, like diabetes, heart disease, those with higher ESS, Epworth Sleepiness Scale before presentation, and in the contradictory, those who have daytime sleepiness and lower AHI, when we do the diagnostic sleep study, those are more likely to have daytime sleepiness even after treatment. Also, daytime sleepiness have been linked more with male sex, while insomnia have been linked with female sex. And the number of hours of CPAP use, also the lower the number, the higher the risk of sleepiness. If we cover briefly the pathophysiology of residual sleepiness and sleep apnea, it's important, again, to know that the duration of the illness is important. Those who have sleepiness for a long time, several years, many years before diagnosis, they may continue to have some sleepiness. We'll talk about that. And again, patients with comorbid conditions, we cover that briefly, like diabetes, hypertension, and other medical problems. Several theories have been proposed why these patients they have sleepiness, but the main two concepts are intermittent hypoxia and sleep fragmentation. These pathological changes, they can lead to neuronal damage in the wake-promoting brain regions, and may affect also the neurotransmitters. So chronic intermittent hypoxia have been shown to affect important brain centers and regions like the forebrain, and affect also the level of catecholaminergic wake neurons, and there is also loss of orexinergic and histaminergic neurons important for wake promotion and excitatory neurotransmitters. While sleep fragmentation have been shown in animal models to affect neuronal degeneration through oxidative stress and also to impair wake promoting neurons in the locus coeruleus. So these chronic changes may have effect mainly in the animal models. What about the human studies? Human studies, several studies have shown that there is a reduction in the white matter, more in patients with sleep apnea and daytime sleepiness, and using the diffuse tensor imaging DTI technique, they also reported higher whole brain mean diffusivity in patients with EDS, and this is probably suggesting possible myelin or axonal degeneration. Not only white matter, also gray matter had been shown to be affected in humans with chronic, with sleep apnea. The longer the duration, the more the effect, and affecting important centers in the brain, including the hypothalamus, frontal cortex, and the thalamus. This reduction has been also documented in the right middle temporal gyrus. The important thing that after 3 months of CPAP treatment, gray matter volume have been reported to increase, and that was accompanied at the same time with improvement in daytime sleepiness and cognitive function in general. Therefore, we have to give some time for treatment and assess adherence. Okay, so if we have a patient with residual sleepiness after proper treatment for sleep apnea, how can we approach this problem? We have to ensure that the patient is treated adequately. How do we do that? By making sure that they are not getting suboptimal pressure, so we have to follow the residual AHI in these patients. We have to make sure that they have good adherence. 4 hours per night may not be enough. The longer the duration of use, the better the outcome. Again, we have to rule out air leak or poor mask fitting. Again, we have to check for possible comorbid conditions that may cause sleepiness. The commonest is sleep deprivation. This is a common problem in all our societies. But other common problems that may coexist is depression. Depression is very high among patients with sleep apnea. It may go up to 18–20%. And also some medical conditions, medications, work schedule. All this we have to take into consideration when we treat daytime sleepiness after treating sleep apnea, before we go and label them as residual sleepiness that needs medications. So to treat residual sleepiness, we have to keep in mind that we have to treat sleepiness and sleep apnea at the same time, not replacing the management of sleep apnea with CPAP or other alternative treatment with medications only. This is very important to keep in mind. Several medications have been approved to treat residual sleepiness in sleep apnea patients, including the famous modafinil and armodafinil, the dopamine reuptake inhibitors, and both drugs in several randomized controlled trials have shown improvement in psychomotor vigilance tests and tasks and other parameters of cognitive function. So both have been used and have been approved in the US. Sodium phenol, which is a dopamine norepinephrine reuptake inhibitor, recently approved for narcolepsy, and after that for residual sleepiness among sleep apnea, have been shown also to be effective even in long-term follow-up up to 1 year in improving sleepiness and cognitive function and quality of life. Recently, vitalazone, which is a selective histamine receptor 3 antagonist, had been approved also for narcolepsy and residual sleepiness in patients with sleep apnea. And the thing about vitalazone that have been tested in both patients who are compliant with CPAP and those who are not using CPAP, and have been shown to be effective in both groups of patients. So in the US currently they have 3 medications approved for residual sleepiness and sleep apnea: modafinil, armodafinil, and solriamfetol, while in the European countries in 2011 they removed the indication for modafinil and armodafinil. They put in their comment that probably higher risk of cardiovascular and neuropsychiatric issues. This is not accepted by all experts, but this is some concern to keep in mind. So in the European countries, they have only solriamfetol and vitalazone now approved. And in 2021, they approved vitalazone for both those who are adherent to CPAP and those not using CPAP. Again, this is a question mark. So how we approach it quickly, this is, I adopted and adapted this from the European guidelines. I found it's better than the American Thoracic Society recommendation. So you assess patients after treatment for 6 months. If they are still having daytime sleepiness after treating sleep apnea, make sure that they have good adherence, other problems like leak, suboptimal pressure. If you rule out all of that, then check for comorbid conditions like depression, other medical problems. If there are no sleep disorders found or other problems, then consider the diagnosis of residual sleepiness. In Europe, they label them as two groups, high cardiovascular risk and low cardiovascular risk. For low cardiovascular risk, they recommend solriamfetol because they are not approving modafinil or R-modafinil, but I will add here modafinil or R-modafinil if it is available in your country that you can use it. However, if you have high cardiovascular risk, they recommended betalazone, but again, if you have for alternative treatment of sleep apnea. If they continue to have sleepiness, then you consider the treatment as we discussed. So what are the concerns that we have as physicians when we treat patients with stimulants, patients with sleep apnea with stimulants? We always have the concern that if we use stimulants, patients may not use CPAP. And if they stop using CPAP, then they may have higher cardiovascular risk because we are just treating the symptoms, which is sleepiness. Then again, if we use modafinil or R-modafinil, which are available in our countries in the Middle East, patients, if they have cardiovascular risk, we have to be careful because there is at least a theoretical concern that it may increase the cardiovascular risk. We always have the dilemma of potential harms versus benefits with all wake-promoting agents, especially for sleep apnea. And the final thing, should we have some clinical characteristics or phenotypes that define which agent to use for which patient? And another concern, should we limit the use of wake-promoting agents only to experts and specialists in sleep medicine, not for the like GPs and other general physicians? This again a concern that we need to answer. What about the upcoming research agenda for the future? It's important to look for indication for wake-promoting agents, in what group of patients want to use it, and what are the parameters to define it. We need also real-life data because all data we have are coming from randomized control trial. We need now big data from big registries to see after a few years of using wake-promoting agents for patients with residual sleepiness among patients with sleep apnea, what are the effects, what are the cardiovascular and metabolic complications of these patients. We need also to assess the effect of using wake-promoting agents on CPAP adherence or adherence to other modality of treatment like mandibular advancement devices. We need also to know if using wake-promoting agents will improve the lifestyle of patients with sleep apnea, making them adopting a more healthier lifestyle and then more physical activity. That's something that needs to be answered. We need also to assess all parameters of cognitive function, not only sleepiness, with the use of wake-promoting agents. And finally, we need to define with clear clinical parameters what group of patients we should use for them wake-promoting agent and what agent for what group of patients. We need to reach a consensus on that. So to conclude here, residual sleepiness is very common among patients with sleep apnea. It can go up to 20% despite treatment. Daytime sleepiness often indicates poor outcome, but its long-term benefits when we use wake-promoting agent, we don't know if that will improve the outcome or not of these patients. Neuroimaging in humans showed neuronal damage, both white and gray matter, but the exact causes of residual daytime sleepiness in OSA patients still is not fully understood. Assessing residual sleepiness in patients with sleep apnea is best done after the initial 6 months of treatment. So we have to give them good time of treatment before we go and use wake-promoting agents. Existing treatment for residual sleepiness in this group of patients has shown enhancement and improvement in daytime sleepiness measure, quality of life, and work productivity, but we need long-term, real-life data, not only data from randomized control trials. Also, more data is needed to guide the selection of the right wake-promoting agent for each patient, and this probably will come from real-life data to see if patients who use modafinil or R-modafinil, did they have more cardiovascular events or more worse prognosis from the cardiovascular point of view or not. Upcoming research also should assess the effect of wake-promoting agent on all cognitive parameters, observed brain changes by doing like neuroimaging and see if affect the anatomy of the brain or not. Thank you, and I'll stop at this stage. Thank you very much.
Thank you, Professor Ahmed, for this valuable presentation. And I have one question, please. I want to ask about your experience with the use of pitolisant in residual sleepiness in patients with obstructive sleep apnea treated by PEP therapy.
Pitolisant, we have used it for narcolepsy. We got it now approved for narcolepsy in Saudi Arabia, so still we don't have the experience with it for patients with sleep apnea because its availability is limited. And also it is recently approved in the European Union, only 2021, not yet approved in the US. So I think the global experience with pitolisant in residual sleep apnea patients who have sleepiness, I think it is still limited.
If you would choose one of the pharmacotherapy for residual sleepiness, what kind of pharmacotherapy would you choose from the list you have mentioned shortly?
I would use for patients who have high cardiovascular risk, I'll go for pitolisant if it is readily available, because it works in a different mechanism, not related to dopamine or norepinephrine. But in other patients who like healthier patients who only have severe sleepiness with sleep apnea but no cardiometabolic problems, then I'll go with the available medications in the country. For example, in Saudi Arabia, we have modafinil is easier to find. Probably, I guess the same thing in Egypt. It's now also manufactured in Egypt. So for patients who don't have cardiovascular risk, I'll try modafinil for these patients, and I'll monitor them carefully initially. And I would go also with the recommendation of having this medication used by specialists, not leaving it for the general practitioner.
How often do you meet the problem of excessive sleepiness after PEP therapy, Professor Ahmed?
It's very common in my practice. And we use for some of them modafinil, but I don't know what's the situation in Egypt. For us in Saudi Arabia, modafinil is not easily to get it because it's not manufactured in Saudi Arabia like Egypt. So we try to reserve it for patients with narcolepsy. But for patients who still have residual sleepiness, I do use modafinil, and I follow them regularly and objectively by downloading the data from their CPAP to make sure that they continue to use their CPAP. Also, they go through sessions of health education to let them know that modafinil will not treat their sleep apnea. It will only improve their sleepiness. For the sleep apnea, it's cerebrocardio and metabolic complications. They have to continue using CPAP. And this is very important to stress to the patient because once they are not sleepy, they tend to stop using CPAP.
Thank you, Professor Ahmed.
Thank you very much.
Any questions from the floor? I would like to thank Professor Ahmed Behammam for being with us today. I'm sorry we have loaded your schedule. Thank you so much for this presentation and hoping for more collaborations in the future. Thank you, Professor Ahmed.
Thank you very much. أنا حقيقة عاجز عن الشكر وأنا سعيد بتواجدي مع أحبتي في مصر وإخواني في مصر. يعني مصر عزيزة علينا جميعا وأنا سعيد بوجودي معكم وشكرا لكم جميعا.
شكرا جزيلا لحضرتك يا فندم. And now we call